Welcome to this fifth and final webinar on preaching in the sciences. It's a project funded by the John Templeton Foundation. My name is Ed Foley, and it's my honor to serve as the project director for this pioneering program, whose presentations from the preceding webinars are now posted online through the CTU website. A basic premise of this project is that the sciences have great potential for enriching the preaching of preachers, especially Roman Catholic clergy, even though they are infrequently employed. So to close that gap, this venture places celebrated scientists and gifted homilists in direct dialogue with each other. The central outcome of this dialogue will be the posting of over 100 homily outlines across the 3-year lectionary cycle in an open access format through the CTU website. I'm grateful to Rachel Kuhn, the Director of Development at Catholic Theological Union, for her presence today and her great help in securing the grant and facilitating and producing these webinars. Thank you, Rachel. Before I introduce our distinguished presenter, Dr. Kathleen Beavis, I'd like to introduce the gifted homilists who are at the heart of this project, beginning with Gerald, please.
Hey everyone, I'm Gerald Wu, ordained in the United Methodist Church and finishing up a stint as a worship and preaching professor at Princeton Theological Seminary.
Thank you, Gerald. Norman.
I live in New York.
Hello, everybody. I'm Norman. I'm a Roman Catholic priest and I'm a pastor of a parish in Southside Chicago.
Hi, everyone. I'm Dan Horan. I'm a Franciscan friar, and I'm on faculty here at Catholic Theological Union in Chicago. And I teach systematic theology and spirituality, and I'm delighted to be a part of this program.
Hello, my name is Father Matt O'Donnell. I'm a Roman Catholic priest and the pastor of St. Columbanus Church, which is on the south side of Chicago.
How are you? My name is Father Adam De Leon. I'm a Jesuit priest working at Loyola High School in Detroit, teaching, coaching, campus ministry, and Ignatian identity.
Kathleen, my name is Ann Garrido. I'm an associate professor of homiletics at Aquinas Institute of Theology in St. Louis, Missouri, where Dominican School of focuses on preaching. And I'm calling in today from Atlanta, Georgia.
And then Greg.
I'm Greg Kandra. I am a journalist and writer and editor in the Diocese of Brooklyn, and I am a deacon in the Diocese of Brooklyn.
Thank you.
My name is Patrick Shebek. I'm a pastor of the Evangelical Lutheran Church in America and the senior pastor at St. Paul Reformation Lutheran Church in St. Paul, and also serve as the ecumenical officer for the St. Paul Area Synod.
I'm Father Samuel Hakim, a Catholic priest and Dominican friar. I live in Chicago, and I'm currently our province's vocations director. So I work with men who are interested in becoming Dominicans.
Thank you. And we're also fortunate to have a terrific student assistant for the project. So Kathleen, would you please introduce yourself?
Hi, everyone. My name is Kathleen O'Brien, and I am currently a student at CTU getting an MA in systematics theology, and I live in Hyde Park. So good to be with you all.
Thank you, Kathleen. We're delighted for all of you honoring us with your presence and the great work you are doing and will do for the project. And now to our presenter. Dr. Kathleen Beavis is a physician. She is professor of pathology and medical director of laboratories quality with specialties in microbiology and immunology at the University of Chicago. Her impressive educational record includes an undergraduate degree in philosophy from Harvard University, an MD from the University of Pennsylvania. She did an internship in anatomic pathology at Massachusetts General and a fellowship in microbiology at the Cleveland Clinic. She was also awarded a Rotary Fellowship studying philosophy and theology at Tübingen University in Tübingen, Germany, and studied with people like Hans Küng. So she brings quite a formidable background. Before coming to the University of Chicago, she was chair of microbiology and virology at Stroger Hospital of Cook County. Not only is she a board certified pathologist, but she's a trustee of the American Board of Pathology and is held in such esteem by our colleagues that in 2009, she received the Lifetime Achievement Award from the College of American Pathologists, especially for her work in bioterrorism and responsiveness. And also, she is awarded for being a Distinguished Patient Care Award. She served on several panels for both the Federal Drug Administration and the Center for Disease Control that included bioweapons training from the federal and local governments. Not only does she have experience with SARS-1 and H1N1 and Ebola outbreaks, but Kathleen also recently taught at Wuhan Medical School in Wuhan, China, the epicenter of the COVID-19 outbreak, which allowed her unique lines of communication with Chinese and other worldwide colleagues in battling this virus. On a personal note, I had the privilege of participating for many years in a theological book club with Kathleen. She lives in Chicago with her husband, Bruce, and her daughter, who's now a senior at the University of Chicago. When we were shaping this project, she was the first scientist that came to mind. And I'm so delightful and grateful for her generosity in joining us, even as her work and that of her colleagues in battling COVID-19 continues unabated. Kathleen, you are most welcome, and the floor is yours.
Ed, thank you so much for your generous introduction. And I especially want to thank all of our homilists for sharing your time and for engaging in this project and welcoming me into your world. I hope that some of what I do will be helpful as you craft the homilies, and I hope that I can be useful to you all during this project. So this is what I call my "What is Science" slide. Science and religion are often presented as antithetical, and I do not understand why. We all know the stories about the Roman Catholic Church in Galileo, and maybe we've even had some personal experiences with well-meaning people who don't understand Catholicism's appeal to the rational and to the tangible. When studying cosmology, I was asked by my mentor if it was hard for me to do. I said no. I had been in other mathematical logic classes with few or no women. He cleared his throat and he said he meant as a Roman Catholic because, well, if the Pope said something was true, don't I have to accept it? I didn't appreciate at age 19, but as I have learned more about my religious tradition as an adult, I have learned about the richness of this tradition. And this tradition includes a rich history of using art, architecture, chant, polyphony, and incense to engage not only our minds, but our senses and whole beings into the presence of God. And now, science. So I was talking about this seminar with my parish priest from Philadelphia, Father John Jagodzinski, and sharing my struggle with preparing this talk. And as he so often does, he enthusiastically blurted out the obvious. My, Kathleen, read Genesis. It's all Genesis. It's all about Genesis. Took his advice, went back to Genesis. And I started thinking, we often hear that we should judge people by their deeds rather than their words. We have God's teachings in the Bible. We have God's deeds in creation. By studying creation, we are studying God's deeds without interpreters, without debates about the authenticity of a text. God's deeds are accessible to all. We can count the rings in a tree, we can taste a fish, we can hear the wind, and we can smell the lilacs of spring. We can look at the stars and watch Jupiter and Mars and feel a bond with all the other individuals and civilizations who have made the very same observations. It's very personal for me. On those summer nights, watching the moon and the planets over the ocean, I'm looking at the same planets Galileo watched, and the same moon and the sun that the Aztecs and the Egyptians charted. This is creation. These are God's deeds, and God did it for us to use, to watch over, and to protect. I am often asked, what does an academic clinical pathologist do? My clinical responsibilities as a physician are to identify causative organisms and effective therapy for patients who have infectious diseases. And as an academic physician, I'm also trying to find better ways, more cost-effective ways to make clinically relevant diagnoses. I often collaborate with my colleagues in the basic sciences, but most of my research is what would be called translational. And that is translating discoveries from the bench to patient care. And as Ed mentioned, I also perform a lot of what we call professional service. I've served on several CDC and FDA panels, and I've served on many committees that write guidelines for others. This includes ISO guidelines, which are international in scope, as well as guidelines for a primarily US audience. I also do a lot of work with the College of American Pathologists, an organization of pathologists dedicated to providing excellence in laboratory diagnoses. And as part of that group, I have traveled nationally and internationally to Asia and the Middle East, inspecting laboratories and working with peers in other countries to help them provide excellent diagnostic services. And as academics, we all teach and we are all on the committees. So this article was in the New York Times yesterday, and it really hit me hard. I am not suggesting that clergy need to become experts in science or engage in debates about the relative merits of one vaccine over the other. But when there are food drives or meals for those who need them, do churches go into the various and conflicting recommendations for a healthy diet before distributing food or feeding the hungry? We all know we can find misinformation in social media, and that the misinformation can come from simple ignorance, as well as from those who like to stir the pot. But I suggest, though, that just as attempts are made to provide nutritional meals to the hungry without becoming an expert in dietary theory, that clergy can be a resource or a link to others for basic health care. And this can be done by partnering with local health officials or healthcare organizations. And I also think it's important that linkage to care be provided. It's not enough to offer to take blood pressures or test for glucose levels or screen for HIV without linking those who need it to follow-up care. And this is what hit me from that article, which is that many people trust you all much more than they trust me. And frankly, especially over the course of this past year, I was not surprised to hear that. As new reports of effective vaccines were published, we also saw that the number of references on social media to the Tuskegee syphilis study also rose. And this study observed the natural course of syphilis in 412 Black American men from 1932 to 1972. And this study continued even after treatment became available, and even though the natural course of the disease had been known for a long time. And again, these 412 men were watched. Their challenges with syphilis were documented, and they did not receive penicillin and other medications that were available. There's a lot of background as to why you all are so well trusted. There's an editorial from the New England Journal about the ethics of clinical research, focusing on what was then called the Third World, that is almost 25 years old. And I have my undergraduate students read it every year, realizing that it was written before they were born. It discusses the concept of equipoise in research, as well as some of the challenges applying equipoise. As physicians, and especially when I trained in the 70s and the 80s, we've had a love affair with what we call the randomized clinical trial. And this is when those consenting to be in a study of two treatments are randomly assigned to one of, for purposes of this argument, let's limit it to two groups. And as written in the article, and I'm quoting, usually investigators hope and even expect that the new treatment will be better, but there should not be solid evidence one way or the other. If there is, not only would the trial be scientifically redundant, but the investigators would be guilty of knowingly giving inferior treatment to some participants in the trial, end quote. And this is the state of equipoise. The Declaration of Helsinki from the World Health Organization states, quote, in research on man, The interests of science and society should never take precedence over considerations related to the well-being of the subject. It also states, quote, in any medical study, every patient, including those of a control group, if any, should be assured of the best proven diagnostic and therapeutic method. These statements seem so obvious. Why are they necessary? It is very tempting when the researcher believes that the work is important and will benefit future generations. It's very tempting to prioritize the research outcomes to the welfare of the humans consenting to be studied. And before the advent of highly active antiretroviral therapy, these are HIV therapies, babies who were born to HIV positive moms would themselves be HIV positive about a third of the time. And in the 1990s, it became very apparent that by giving the drug AZT to pregnant women, we reduced the odds significantly that their child would acquire this disease at birth. And the clinical trial evaluating the efficacy of this medication was halted before its endpoint because the results became so apparent so quickly. And AZT quickly became the standard of care for HIV pregnant women in the United States. But what about pregnant women in other countries? The cost of AZT at the time was so expensive. While women in the United States received AZT, trials were conducted with alternative regimens in developing countries. But the problem with these trials, though, is that the alternative regimen was compared to a placebo. I will please, that is no therapy at all, rather than to AZT, a medication already proven to be effective. And there were arguments, and there still are arguments, that these women wouldn't have received therapy anyway, so what was the harm? The research question tested was, are these alternatives better than nothing? These trials would not meet the concept of equipoise. And in any medical study, every patient, including those of a control group, should be assured of the best proven diagnostic and therapeutic method. When I was in training, don't know what that was. When I was in training, there was usually a placebo arm in randomized controlled trials. And over the decades, we have made a lot of progress and realized that this is not always appropriate and can be ethically dubious at the least. Nevertheless, the history of clinical research and the relative valuing of different patients is well known and remains an obstacle to recruiting among several groups for clinical trials. And we saw this when we were recruiting patients for the COVID vaccine trials. Historically, many groups have been excluded from clinical trials, especially pregnant women and children. The problem with excluding groups, though, is that we don't know if the treatment will work on these groups. And because the harm from COVID was disproportionately focused on non-white populations, it was important to demonstrate that the vaccine trials would be effective in these populations. The University of Chicago and the University of Illinois at Chicago were especially successful in recruiting members of the Black community and the Latinx community to participate in these trials. Nevertheless, skepticism persisted. Even though the intention was to be inclusive, there were allegations that members of these groups were being recruited to serve as guinea pigs for everyone else. Another disease that has disproportionately affected Black and Hispanic communities is HIV. I was a physician at Cook County Hospital for 13 years, and we have a very large HIV clinic. It was 7,000 patients when I left, and that was seven years ago, so it's only grown since. When one is frequently dealing with the best ways to diagnose and treat a disease, and when one is constantly seeing patients with the disease, any stigma falls away. Yet this stigma about HIV remains even in young people. And what do I mean by stigma? Well, try this thought experiment. How would you feel if blood was being drawn during a health visit and you were told it was for a thyroid test? How would you feel if you were told it was for an HIV test? Early recommendations for HIV focused on those engaged in risky behaviors and those living in areas with a high prevalence of HIV. The recommendations have changed, and I'm hoping we can spend some time talking about these recommendations and the benefits as well as the challenges of screening tests. So let's talk about the power of prevalence and HIV screening. HIV screening was initially recommended based on risky behaviors and demographics. Right now, the CDC recommends that everyone between these ages gets tested for HIV at least once as part of routine health screening. And for those with specific risk factors, testing is at least once a year or more frequently. And again, for this thought experiment, how would you feel if you were at your physician's office, blood was being drawn for all the normal stuff, and they said they were drawing an HIV test? So, science is a team sport, and we are going to have some fun. I want to show you some of the challenges because we talk about screening populations for disease. There are pluses and minuses to it. And I want to dive in a little bit to show you what some of the challenges are and to show you why this has been controversial in certain populations. So I hope we're going to have some fun with this. We're going to talk about sensitivity, specificity, prevalence, and positive predictive value. But before we do that, we are going to define our terms. So when I talk about a laboratory test and I talk about its sensitivity, I'm talking about the ability of an examination or a test to detect disease in those who have it. So sensitivity is, will the test pick up those who have the disease? So just as you want a test to pick up those who have a disease, you don't want it to pick up the disease in those who are healthy. And that's where specificity comes in. So specificity is the ability of an exam to detect health. So when we talk sensitivity, we're referring to how well does it work in people with the disease. When we talk specificity, we're referring to people who don't have the disease and how well it can distinguish that group. Prevalence, we're talking about the percent of population with the disease. And obviously the prevalence varies. If your population is a sexually transmitted disease clinic, well, your HIV prevalence might be 20%. If your prevalence is in a part of the country that doesn't have much, your prevalence might be 1 in 10,000. And the fact that prevalence varies in populations will make screening more or less useful. So, positive and negative predictive value. Let's say that I'm a physician and I'm getting all my lab tests back on a Friday afternoon. And I've got my pile of positive test results, my pile of negative test results. If I'm going through, okay, and I first want to disabuse everybody of the notion that just because it came out of a laboratory and is on a piece of paper that you get the right result, all right? In microbiology, in general, when we have a bacteria and we test it against 20 different antimicrobials, one of our results is going to be wrong. It just is. So we all do the best we can, but it's important to realize that none of these tests, as good as they are perfect. So what do I mean by positive predictive value? Let's say I have 100 positive test results. Well, are they really positive, or is it a positive result in someone who doesn't have the disease? What's a negative predictive value? I have a stack of negative test results. It says they're negative, but are these people really negative? How many of these negative test results, what percentage of them correlate to people who really do not have the disease? And this will get clearer as we move along, I promise. So, and this is something that I stress with the undergrads and the medical students, that sensitivity and specificity are fixed characteristics of a test. I think Americans have heard more about the FDA this past year than they've heard in the past 20 years. And one thing that with the FDA is that when a test is approved or cleared, it comes with a package insert. And as a pathologist, I live and breathe these package inserts. And it says how well for each test, you know, the sensitivity and specificity are in the insert. And these are defined characteristics. What I want to demonstrate is positive and negative predictive value will vary with the prevalence. And again, this explains why screening can be challenging in certain populations. So let's look at what to me is a really good test. And again, this is an HIV test. The sensitivity is 99.9%. So if you have 1,000 people with HIV, it's going to pick up 999 of them. Specificity, 99.9%. If you have 1,000 healthy people, it's going to give you a negative result in 999 of them. Let's take that sexually transmitted disease clinic I referenced a little earlier. And let's say that of all the people coming in there for syphilis, for gonorrhea, for chlamydia, for whatever, that 20% of them also have HIV. All right. And then we're going to work our way towards the positive predictive value. There is a reason I'm taking you through this. So let's assume that we have 10,000 patients. And I always try to tell the students, pick your numbers to make it easy on yourself. Start with 10,000. Well, we said that 20% of them had HIV. So we have our 10,000 patients across the top. 2,000 are HIV positive, 8,000 are HIV negative. And remember, positive predictive value, can I believe a positive? So the next step is fill in the true positives and the true negatives. So sensitivity, that deals with those who have the disease. So 99.9% of them are going to get a positive test result. Let's do specificity. 99.9% of healthy patients. So 99.9% of this group is this number here. And the plot thickens. Because the third thing we have to do is then to look at the false positives. And again, the false positives are these positive results that we're going to get in healthy people. We started out with 8,000 HIV negative patients. We got a negative result in this many of them. So this means that 8 out of our 8,000 people are going to get a positive result, even though they don't have the illness. Similarly, let's look at the at this result over here. We started out with our 2,000 HIV positive patients. We got a positive result in 1,998 of them. 2 of them are going to get a negative result. It's just the arithmetic. That's all it is. So here it is. It's Friday afternoon. I get all of my positive test results back. It's going to be a busy Friday afternoon if I have to make all these phone calls. No, the stuff all goes electronically to public health, thank heavens. But what this means on that Friday afternoon is that I have a total of 2,006 positive HIV results, 1998 from this group, and then 8 from this group. And as we go further, we will realize that 99.6% of the positive results were actually true positives and belong to people who have the disease. Okay, this seems very intuitive, and this is what we would expect from medical testing. Let's take the next scenario. Remember, it all comes down to prevalence. Here I've changed the prevalence. Here the prevalence is 1 out of 10,000. So we've moved away from our sexually transmitted disease clinic, and we are somewhere really, there are parts of the United States where the prevalence of HIV is this low. So let's put ourselves in one of those neighborhoods. And out of 10,000 people, again, I always keep the same numbers to make things easy for myself. 1 is HIV positive and the rest are HIV negative. And I always tell the students, do it the same way every time so that you build the habits. So let's fill in what we know. We know that the sensitivity or its ability to detect disease in someone who has it is 99.9%. So that person's going to get a positive test result. For our patients who are healthy, again, 99.9% are going to get a negative test result. And this is where we are here. This is looking good so far. But this is where the plot thickens. When we fill in the other blocks, there's no false positives. We only had there's no false negatives. We only had 1 patient. The disease was detected. Look what we have over here, though. With our healthy patients, 0.1% of them are going to get an inaccurate result that says they have HIV. It's now Friday afternoon. I'm looking at this is much nicer. There's only 11 positive test results that I have to deal with, but only 1 out of the 11 is positive, 9%. It's a very different situation from the sexually transmitted disease clinic where the prevalence was much higher. So why am I going through all this? I really want to demonstrate that when we talk about screening for disease, as useful as screening is, that it has limitations. And the limitations are primarily based not on how good the test is. I mean, we have a test that is pretty good here, 99.9%, but just how important prevalence is in the group that you want to screen. So again, for specificity and positive predictive value, for positive predictive value, can I trust a positive test result? Negative predictive value, can I trust a negative test result? And as screening moves into populations with a smaller prevalence of disease, the positive predictive value will decrease. So why is this relevant? When we think about why there isn't a lot of trust in medicine and why you all have still such a great power of trust, a lot of it has to do with inaccurate test results. It has to do with a history of research, some of which I have detailed. And we have such faith that if we get a laboratory result on a piece of paper, that it must be right. And what do we tell the pregnant woman who's in labor that, oh, we think she might have HIV, we're going to have to do a C-section, and she can't breastfeed? How do we handle that when we realize that the HIV result was a false positive result? And I have to tell you, this has happened to me several times in my career. And you might say, well, how is this relevant? Well, think of who doesn't get a lot of prenatal care. The women in who we have to do HIV test results on when they come to give birth, are typically women who have not gotten prenatal care, or we can't access their prenatal care charts. And when you're relying on a test, mistakes happen. So I am a believer in screening for HIV. I have to tell you that when the recommendations changed, a little bit over 10 years ago, I didn't understand why we should screen. I kept saying, look, let's look at people who are using illegal drugs. Let's look at people who are practicing homosexual sex. Let's look at people who live in zip codes or other demographic areas where there's a lot of HIV. The Willie Sutton, let's rob the bank because that's where the money is. And when I was at Cook County Hospital, we started screening people. And when we looked back at the medical record of those in whom we had picked up based on screening, and these aren't people who came in with thrush or with other things that said, hey, screen them. These are just people picked by peer educators and who were screened for HIV. We found that on average, these patients had had 5 prior contacts with the health system. And that's 5 missed opportunities to not just diagnose them, but, and this is something that is really important to me, to link people to care. Even though I spend so much of my time working on good diagnostics, clinically relevant, cost-effective diagnostics, I don't believe we should be doing diagnostics if we're not linking people to care. And when we looked at the people who we had missed, a lot of these people were in late stages of HIV. They had frank AIDS. There were still a number of people that were in the earlier stages, but we really missed the opportunities not only to treat those people, but to prevent the transmission of further infections from them to others. So I am a believer in screening. And I went through that exercise in arithmetic, though, to show you some of the challenges with screening and that it's not a panacea. And also to illustrate why there's some distrust with screening. So as I've mentioned, screening was initially recommended based on behaviors and demographics. It's now recommended, especially a lot of young people, they get tested once a year. I hope that after this, if your doctor says, oh, and I'm testing you for HIV as well, that there's a little bit more understanding as to why that's happening. But there's a lot of work that we've done to try to reduce the stigma. And when I was at Cook County, what we did was that whenever anybody was getting any blood drawn, they would just be informed that part of it was an HIV test. And this was not out of the blue. They were big signs in every language. It's funny. Usually when I go into healthcare settings, I'm used to seeing things in Spanish because that's the most predominant language. Well, in Cook County, the first language was Polish. Okay. And then it was Spanish, and then it was Vietnamese. These signs were all over. And we were telling people that this is just part of our routine practice and this was going to happen. We wanted to destigmatize the testing. So that's something that we've done. When I came to University of Chicago, they were not doing this. We're doing a lot more of it, but it's not an easy thing to do because again, not only do you want to be able to make the diagnosis, you have to have the resources to link people to care and to make sure that they get not just the drugs, but also the education and a chance to talk about behaviors and different risks. I mentioned the challenge of doing HIV screening when women are in labor. And I want to let you know about a situation that I've run into way too many times. And this is when a woman comes in to give birth, and we either don't have access to her prenatal care or she did not have prenatal care. And there are different kinds of HIV tests. They've gotten progressively better since the late 80s, early 90s. And they're now able to detect a disease earlier in its course. When we first started with HIV tests, someone had to be positive for even 6 to 8 weeks before the test would pick them up. But now with a lot of the screening tests, we can pick up HIV, in 2 to 3 weeks after the infection has started. But as each test gets better and better, there's more and more of what we call false positives. And again, as you know from what we talked about, that's when a person who is HIV negative gets a positive result. So there's now a 4th generation HIV test, we were using that on women in labor. And we had 2 false positive results that resulted in C-sections, emotional distress, and later an additional testing showed that these were false positive results. Well, what do you do with this? It's funny, a bunch of my colleagues, when they think like there's a list there, it's called the Beavis Rules. But one of the sayings that they attribute to me is, what mistake would you rather make? And I had never really thought about it until a bunch of people pointed it out to me. When we have discussions, when we have challenging discussions, a lot of times the emphasis is on, well, what's the right thing to do? What's the best answer? And it always struck people that I would approach it sort of backwards. What mistake would you rather make? What error is preferable? And that's what I was talking about with these HIV tests. What would you rather do? Would you rather detect more HIV infections with the cost of false positives, C-sections and so forth? Or would you rather miss some HIV infections, avoiding a C-section, but then you're risking getting an HIV positive baby born to a mom who's HIV positive? So after we had 2 moms fairly close together, receiving C-sections that down the road were shown to be unnecessary, the decision was made to switch back to the 3rd generation test. And this was really hard for me as a pathologist. As a pathologist, I don't spend as much time with patients. My, emphasis is on numbers. I look at data. I try to do the least harm. And the decision was made anyway to switch back to a test that just wasn't quite so good. And you all know where this is going. We only had to wait about a year for this. But a third trimester HIV test was performed at a woman who got great prenatal care. And after she went to her prenatal visit, she came into the hospital to deliver, but the results from her prenatal care weren't visible to labor and delivery. And they did a third generation test during labor. That test was negative. When the test that was done at her prenatal visit, though, came back, that test was positive. And so this was an HIV positive woman who gave birth. And as it turns out, her child is HIV positive. And I view it as a preventable disease. The challenge with this, and then we've subsequently switched back to fourth generation, the challenge is that even though we like to think of medicine in particular as being very rational, I was very comfortable arguing for a fourth generation test. I was very comfortable arguing for C-sections when they weren't necessary, because to me, that mistake was preferable to the mistake of an HIV child being born. But I think other people who were much closer to the patients and had to have those conversations, not just with the woman about to give birth, the conversation, especially if her partner is there, oh, by the way, we think you might be HIV positive, and that's what the test is saying, and let's do a C-section. That's an incredibly difficult conversation to have. And when I was at Cook County, I was involved with these patients when we had these discussions and when we had to talk about breastfeeding and so forth. They are very painful conversations. And so there was not a consensus that we should stick with the fourth generation test. As we move on, and before we close, I do want to talk about what I'm calling the elephant in the room. And that's, I want to say a few words about COVID and just how we handled that. As Ed mentioned, I had the privilege of teaching in Wuhan in 2015. The University of Chicago has a collaboration with the medical school in Wuhan. And, as many of you have heard, education, not just in medicine, but in many fields these days, it's more participatory, it's more problem-based and so forth. Wuhan was the traditional medical education. There's a lecturer standing in the front of the room with a fire hose and just spewing out the information. And that's what these kids got all day. They wanted to get some exposure to American methods of teaching. And so I got to go to Wuhan, which was fabulous. I thought it was odd that they asked me to speak about tuberculosis. I do a lot of work on tuberculosis in the United States. But I felt like going to China and giving a TB lecture is like carrying coals to Newcastle. But nevertheless, they were very patient with me. And, I was able to lecture and I was able to teach a small group, sort of the American ways of teaching, where it's case-based, we unfold, the students volunteer. I kept in touch with the people with whom I taught all over in Wuhan. And I think that's the only reason that in December, I became aware of the respiratory illness that was spreading in Wuhan. And I don't know, I've looked back through The Economist, I've looked back through the Wall Street Journal. I don't know where I first saw the reference to it, but this is something from the Wall Street Journal on January 8th. And wow, what a way that we've come then. And, if you ever need to learn humility, I'm going to say become a physician and handle a new disease that is rapidly evolving. One of the things that's really important is that as much as I am so focused on data and numbers, we can only do what we do because I have a lot of people in my laboratory. 40 to 45 individuals, many from the south side of Chicago, are the ones who were doing all the direct patient testing. And after Christmas last year, when I was in touch with my colleagues from Wuhan, I came back to the laboratory and we started preparations on January 6th for this disease. And so much of being able to, having done the diagnostics, is having the support of the people in the laboratory. And I had to reassure them. I did not want them scared. I wanted them to know that I had their back, that we had done this before, We took care of rule out Ebola patients. And frankly, I was a lot more nervous about that than I was about this. But then this is where all those decades of experience come together. I had been trained in how to handle bioterror agents. I knew a lot about the SARS that spread from Southeast Asia to, we had an outbreak in Toronto in the early 2000s. And MERS, I think for most people, that's the Middle Eastern Respiratory Syndrome, came and went pretty quickly. So that was the one on the Arabian Peninsula, and I thought it was gone. But frankly, when I was over inspecting some laboratories in Saudi Arabia, and this is just 2 years ago, I was in these laboratories and I'm like, wow, why do you have all these test kits to look for MERS? And they're like, because we still have a lot of it. And you realize that when you're in a closed society like Saudi Arabia, you're not, the news of what they have is not going to make it out to the rest of the world. So frankly, when we got the tip that there was this respiratory virus in China, frankly, I felt that we were as well prepared as we could have been. But it was a lot of effort was spent talking with the technologists who were actually going to handle the samples and making them feel that what they were doing was safe. I knew in my head that we were safe, but I'd had the luxury of thinking about it for so long, talking to colleagues in Italy, talking to colleagues in Asia. They had not had that luxury. And frankly, it took them a while until they felt safe. Finally, in March 15th, we were able to start testing at the University of Chicago. And this testing was brought up quickly, but that doesn't mean it was brought up sloppily. I was ready when I had access to the reagents. I had done my prep work. I got access to a ton of specimens with influenza, with other coronaviruses and other respiratory virus from the previous year. I keep them in a freezer. We're all pack rats. So that when I had the reagents to test for COVID-19, I had everything ready to go. And so we were able to bring up this test in about 36 hours. And in our first run of 10 patients, one was positive. This summer, you all heard about reagent shortages. We were sitting pretty. We had a ton of reagents because I had done a lot of work with these companies. I'd had like a 30-year relationship with one of them. And, they picked us as the one spot in the Midwest where they were going to, give us reagents. But then things started shifting and Arizona and Texas needed them. And we were really worried that we were not going to have enough specimens to test. And so some of you heard about pooling. We chose to do this at the University of Chicago. And you lose some sensitivity. And pooling is you put specimen from 5 different patients in one tube and you test that tube. And you're not going to pick up. So for the patients who have a very low amount of virus, we're going to miss that when we pool. There's a reasonable chance we're going to miss it. But again, you're between so many hard places. What are your options? Do you have some decreased sensitivity? Do you say, sorry, we don't have enough reagents. We're not going to test you. We only tested the first 100 people who came in today. Or do you do what a lot of people did and they sent them to national reference labs where the turnaround time was 10 to 14 days? I'm sorry, to me, 10 to 14 days, why bother? I felt of what mistake would I rather make? And so we chose to pool specimens and have decreased sensitivity. And as part of that, I hope you got from the earlier part of my talk that it's important to be ethical. It's important to be transparent. And we tried to do this as ethically as possible. We were very transparent for the specimens that were pooled. We put a comment on the result that said, this is a pooled specimen with some decreased sensitivity. And we arranged that if any of those people still had symptoms, they would come back and they would get, a singlet testing and not be pooled. But I thought it was very important to be transparent. Vaccines for healthcare workers, just like we did with COVID. This is a note that I sent to our laboratory in the beginning of December. I knew the vaccines were coming in. I knew that we would have a lot of vaccine hesitance within my laboratory. And unfortunately, I was proved right by that. What I did find effective, though, was to speak one-on-one with people. I put this out in general to the lab. And I was surprised. I was pleasantly surprised. A lot of people did come into my office and talk one-on-one about the vaccines. In the last month or so, when we've had a few holdouts, I've talked to them, I've gone to them and said, hey, what can I do? Is there anything I can do to help you make this decision? I was surprised. There was one guy who said, I just needed to hear about it from you. And again, I think this is the power that you all have, as respected members. A word from you means a lot. And then I want to close with this slide. I don't know if any of you have ever been to China, but like they have the cutest little signs, like on this one on the right on the wall. And this is one of my favorites. I've taken a picture of it and I use it in a lot of my lectures. But I also wanted to show you this email that I got very recently from my colleague in China, in Wuhan. And I'm just so glad that she and her family are doing well. And I hope that I have the opportunity to work with her again, whether she comes to Chicago to teach or I go to Wuhan to teach. Anyway, thank you very much. I really appreciate your attention. I really appreciate your time. And I think it's a marvelous project on which you're engaged, and I hope I can be of some use.
Excellent. Thank you.